couldn't show that chemoprevention is the solution. And we were discussing a lot per email, and I said, okay, so talk about this. You have 5 minutes more. I gave you this because we are discussing about it, so you can talk 20 minutes. That's maximal, and 5 minutes for discussion, but that's it.
Okay,
21 minutes, I will cut something.
This is a great challenge. First of all, thank you, Smachi, Franz, for having me back. This is by far the most wonderful meeting that I ever go to. I've been coming since 2004, with only one missed year, I think. And thank you again, and thank you all for staying. You exceeded my expectations, but the room being this full. And so let me just jump right into this. This is the title that Machi gave me. I modified it just a little bit to say the old dog still barks. Unfortunately, no disclosures. A quick overview. What we'll try to do in the next 20 minutes is, to cover a decade of chemoprevention research in prostate cancer. We'll start with the definitive trials, SELECT and PCPT. There are some new data to tell you about. A very interesting paper from August in New England Journal with PCPT long-term follow-up, and a paper literally 1 week ago that came out looking at some very interesting analysis of the SELECT data that I'll show you. And in addition, these trials, because we collected biospecimens as we did the trial, we're able to have some observational studies that I think give us insights. This is observational data, of course, hypothesis generating, but a lot of provocative data, particularly from the PCPT, and where we had end-of-study biopsies, and so these case control studies are unique in that we had biopsy negative controls. So I think it makes for some more interesting than the usual observational studies. And then in the last few minutes, I'll spend very little time here, but I just want to tell you about my experience at the NCI over the past really 18 years, doing small trials to try to see if we can find a signal and maybe move something forward. And we have not had a lot of success, but I'll tell you about how we're evolving our thinking to think about chemoprevention agent development, given the constraints that we have in that area. So first, a quick review of the PCPT trial. PCPT, of course, stands for Prostate Cancer Prevention Trial. This was a randomized trial of finasteride in over 18,000 men. They received drug or placebo for 7 years, and at the end of 7 years were asked to undergo an end-of-study biopsy. We'll jump right to the first publication of the results in 2003 in the New England Journal, which, as I think everybody probably knows, showed a 24% relative risk reduction in total cancers. This is a 6% absolute reduction. But as we know, the benefit was all in the low-grade tumors. These are mostly Gleason 6s, and there was a substantial reduction in Gleason 6s, but a small but statistically significant increase in the high-grade tumors. And of course, this has caused a lot of problems for this drug and this entire class of drugs, the 5-alpha reductase inhibitors. So the title of my talk here in 2006 was, Does Finasteride Make the Grade? And we'll summarize that presentation in 3 slides. We know from our analyses of the PCPT data that the PSA performs better in men on finasteride. Finasteride actually makes the PSA a better test, as shown by improvements in the ROC curves. And this is true for overall cancer, as well as for high-grade and very high-grade. This doesn't quite make statistical significance because of small numbers, I think, but as you can see, the ROC curves are shifted up and to the left for all cancers, suggesting that there is some element of detection bias because when you're on finasteride, PSA performs better. There's also an element of what we call biopsy bias, and the finasteride actually improves biopsy performance. And this is evidenced by the finding that if high-grade cancer was found at prostatectomy, which of course is the gold standard, you were significantly more likely to have found it on biopsy in men on finasteride, 50% versus 70% versus 50%. So I think this is, pretty strong evidence that there is at least some element of detection bias. And what I like to say is that detection bias accounts, at least in part, for the observed increase in high-grade prostate cancer in the PCPT. Well, the FDA's position on this, probably you all are familiar with, is that the 5-alpha reductase inhibitors only decrease low-grade cancer. Only is their word, that's why it's in quotes. And you cannot rule out a true increase in high-grade cancers, and that a, quote, high level of certainty about benefits and risks is required for prevention agents to be approved. Well, my comment to this would be that it's true that we only prevent low-grade disease, but this could reduce the prostate cancer incidence by 30,000 men per year, and that's actually using the conservative estimates of the FDA, which did not want to accept the reduction in the cancers that were only found on end-of-study biopsy, saying those were not cancers that we would have otherwise found. So just using a 17% reduction, which is what the FDA's estimate was, you still could have 30,000 fewer men being treated. Now, in a perfect world where we have ways of managing these men without treating, that's not so bad, but the last time the CAPSURE database looked at this in the States, we were still treating 90% of low-risk men. I think that's better now, but we're still treating a lot of these men. The FDA said we cannot rule out a true increase in high-grade disease. That is correct. It is, as Ian Thompson said at the FDA Advisory Committee meeting, it is really unknowable. I think all we can say is that the biases that we think were in play would account, at least in part, for the observed increase. But I think that it's true that the increase is rather small. And lastly, the high level of certainty. I would ask you, do you think that that may be setting the bar a little bit too high? When in science do we have levels of certainty? I think that's a strong word. I'll now jump to the most recent publication, which came out in August, the long-term survival of participants in the PCPT. And this is an analysis that was based on the Social Security Death Index. So very importantly, it does not give cause of death. So this is an overall survival analysis. And what was shown is that nearly identical 15-year survival estimates for finasteride and placebo, 78 versus 78.2. And this, the editorial that went along with this said this was reassuring. But I have to say that I'm not so sure this really helps us sort out the high-grade disease issue at all. This study was severely underpowered to assess the impact of the high grade on the, to answer the question, was the high grade real versus some detection artifact? There were only 47 more high grades on finasteride, and we would estimate, we're not given the number in the paper, but we can estimate about 40 more Gleason score 8 to 10s. And given those numbers, you would actually need 4.7 million people to have a power of 75%. And so I think that many people have looked at the New England Journal data and say that we now can be completely comfortable about the high grade. I think that will be an overreach. To put these numbers into context, we know in the ERSPC, a study that was more than 8 times larger than PCPT, which did show a 20% prostate cancer mortality reduction, the rate ratio for death from any cause was 0.99 with a p-value of 0.5, which is why we don't use overall mortality as an endpoint for screening trials. It's just, you don't have enough impact from prostate cancer on overall mortality. So I think that's kind of a caveat that it deserves to be mentioned, despite the fact that this was in the New England Journal. But I will say the PCPT has taught us a lot about prostate cancer. How are we doing here? 10 minutes? Okay. One of the most interesting things I think we learned from PCPT had to do with the fact that we had this end-of-study biopsy. And we were able from that, 2,950 men underwent an end-of-study biopsy, and the overall cancer rate in prevalence in that group was 15%. This was so much higher than the initial estimates that it was really quite shocking. Now I think we're used to the number, but the rates of positive biopsy are not that different from 3 to 4 than they are between 4 and 10. And even at levels of less than 1, we see a real risk of having a positive biopsy. But the good news is that you're very unlikely to have a high-grade cancer. So only 15% of the 15% was high grade, so only about 2.3% of cancer in men with PSAs less than 4. I may not have made this clear, but the end-of-study biopsy was only done in men whose PSA was less than 4 every year for 7 years with a non-suspicious DRE. And so in this group, the high-grade risk was really very low. So I think this actually is a good argument to not be lowering the PSA threshold in order to find more low-grade cancer. As I mentioned, we had observational studies in PCT that were made possible because of the biospecimen collection, where we can measure serum levels and the biopsy negative controls. And I really wanted to give you a lot of references. These slides are available, and so I'll go too fast here to maybe get them all down, but I'd like to quickly just give you some of the highlights of these observational studies. We found that prostate cancer risk was not associated with serum lycopene levels. Alan Crystal, who's been here a couple of times, did that work. It was not associated with any dietary supplements. Now, this was done with a food frequency questionnaire, not serum levels, but there's some dietary findings based on serum levels that I'll tell you about in a moment. Elizabeth Platts published on the lack of association of statin drugs with incidence. We heard yesterday that there, in a different context, Dr. Platts has published on an impact on prostate cancer mortality. Here we had too few cases to talk about prostate cancer mortality, but I think, interestingly, no impact on incidence. A burning question at the time the study was started was the role of the CAG repeat length as a risk factor. It was thought to be shorter CAG repeats increased risk, and that seems not to have been the case based on PCPT. We did find strong associations for obesity that were independent of diabetes, and these results are absolutely fascinating. Alan Crystal was the senior author here once again, and so I really recommend taking a look at this paper. The literature on obesity is very contradictory, and I think we may have figured out why. It appears that obesity actually reduces the risk of low-grade disease, you see with significant confidence intervals, do not include 1, but it increases the risk of high-grade disease. At the same time, diabetes seems to decrease the risk of both low and high-grade disease, and these effects, again, were independent. So this creates more questions than answers, for sure. In an effort to look into mechanisms, in separate studies, Marion Newhauser looked at C-peptide, leptin, IGF axis analytes. We found that high versus low C-peptide levels was associated with nearly a doubling of high-grade disease. Leptin was not associated with high-grade, and I think unexpectedly, the IGF axis analytes were not associated with prostate cancer risk. Now, here's one of the more provocative findings, and this is, we're going to see 2 slides on this, one from PCPT, and then in a few minutes, if I have the time, one from SELECT, showing the effect of fish oil on high-grade disease. And to the contrary of what we heard this morning in a cell line study, we have a counterintuitive finding that omega-3 polyunsaturated fatty acids, fish oils, substantially increase the risk of high-grade disease here in PCPT, again with significant confidence intervals. The omega-6s had a non-significant slight reduction in risk. And again, this is based on measured levels of phospholipid fatty acids, not on frequency intakes. And I hate to end PCPT on a down note, but it may be worth mentioning that heavy drinking, described as 50 grams a day or more of alcohol, another way to say it is 4 drinks a day on 5 days a week or more, was associated with about a doubling of the high grade of prostate cancer and completely attenuated the benefits of finasteride. So again, interesting data from observational studies. Let me now move to the SELECT trial, Selenium and Vitamin E Cancer Prevention Trial, a 2x2 factorial design. And the results, we'll go right to the results published in JAMA in 2009, showed no benefit for any of the supplements and a worrisome trend for vitamin E, where we had a 13% increase in the hazard ratio of prostate cancer. It was not statistically significant. When these results became apparent, the study wasn't stopped, but we stopped the supplements. So we kept the study going, told participants to stop taking their supplements. At this point, it was clear we were not going to see a benefit and that there could be a harm. And in addition to prostate cancer, we looked at lung cancer, colon cancer, all cancers, all deaths, no benefit. No particular signal for harm here, but no benefit. 2 years later, the update published again in JAMA, the increase in the hazard ratio for prostate cancer now reached statistical significance, 17% increase. Notably, there was no increase for the combination versus placebo, which is very interesting, given that there was no decrease for selenium. So we have a scenario here where selenium seemed to protect you from the harms of vitamin E, which was something that was not really very straightforward. And it took us 10 years to get the baseline selenium data that I'm going to show you in a minute because of technical problems with some of the assays. The very first thing we wanted to do was look at the results of SELECT on the basis of the baseline selenium levels. We'll get to that in just a second. The question is, what went wrong? Was it the wrong dose of vitamin E?
4.
We were using 8, there's so much
4
to say
minutes.
about it. 4 minutes?
Yeah.
We used 8 times the dose of vitamin E than had been used in the Finnish trial, the ATBC trial, which is one of the things the main study that motivated us to study vitamin E. We used a higher dose. We used a different formulation of selenium than had been used in the study which motivated the selenium. So these are all potential issues. And maybe we studied the wrong cohort, as I alluded to a moment ago. A low selenium cohort might be the group that would really benefit. And that had been suggested by prior studies, that selenium might work in a low baseline selenium population. We finally got the baseline selenium data just last week. This is the study that was published last week in JNCI. And what we found was that low baseline selenium status was not associated, selenium status was not associated with risk in the absence of supplements. And selenium did not decrease the risk among men with a low baseline selenium. However, vitamin E doubled the risk of high-grade disease in men with low baseline selenium. And also among men with high baseline selenium, any selenium supplementation doubled the risk of high-grade disease. So we don't have the scenario of selenium supplementation helping, but you should know that the low selenium group in this study was equal to the high selenium group in the old study, because now everybody gets selenium in their diet because of the way the food is transported around the country and selenium is put into food. Again, with fish oil, we looked at levels of plasma phospholipids that were measured. Again, omega-3s, highly associated with a rather strong increase in high-grade disease, low-grade disease also, but the important thing is a 70% increase in high-grade disease, and the PUFAs, the omega-6 PUFAs, associated here with a significant reduction in risk. So counterintuitive findings. However, to put this in context, it's rather consistent with the epidemiological literature showing pretty consistently that fish oil is increasing the risk of low and high-grade disease. We have to stay tuned for several sub-studies in SELECT, which I won't go over, and we'll just turn to the very end. What have we done with our agent development program? We've mostly looked in the pre-surgical window of opportunity trial where we have a short duration to give an intervention. You go to surgery, the prostate comes out, we look and see, is there a signal? Does the drug get to the gland? This is a list of the drugs or agents that have been studied in the last 10 years. Ongoing is genistein and vitamin D and metformin. So we've completed these studies. And just to sort of summarize all that work in one slide, for polyphenol E, which is the green tea catechins, and DIM, which is the stable metabolite of indole-3 carbinol, which is found in cruciferous vegetables, we found, interestingly, no tissue accumulation. So that's a good thing to know, but when you want to study a drug for prevention, does it get to the gland where you're trying to have an effect? The answer was no. On the other hand, metformin had excellent tissue accumulation. This study is still ongoing, but I just learned from the PI that they do have these data, so you're the first to hear it. And what I think makes metformin a little bit more interesting for potential for prostate cancer prevention because it gets to the gland. We have not seen biomarker modulation. In addition to looking at drug levels, we look at, are we modulating a biomarker? And the frustrating thing is that we haven't seen biomarker modulation, except with finasteride, which you would expect. But it could be because of the short duration of exposure, insensitive biomarkers. These could be false negatives, which is why I think we need to move beyond this window of opportunity study and look at longer-term studies. We can do longer-term studies with a high-grade PIN cohort where you can treat for a year. We did a study of selenium in that cohort. It's a very important study. It took a long time to do, a lot of work. The bottom line was absolutely no difference, 36% approximately rate of prostate cancer in the two arms. I think actually codifying high-grade PEN as a true risk marker, since 36% is pretty high, but no benefit for selenium. The last study I want to tell you about is the one I'm actually most excited. And the evolving concept of prevention, at least in my thinking, is to think about preventing progression in men on active surveillance. We have in development a study of PSA TRICOM vaccine. PSA TRICOM is a PSA-targeted poxviral vaccine. Very interesting results from a randomized phase 2 that I did mention yesterday, 125 sample size with metastatic castrate-resistant prostate cancer, a 44% reduction in death, and an 8.5-month increase in median survival. These are the survival curves, and they look exactly like the survival curves for Sipuleucel T, which is the vaccine that has been approved for prostate cancer. So we are currently, again, this is the Prostavac vaccine, phase 2, and the Sipuleucel T. The phase 2 look just like that, and that's the phase 3. We're doing a phase 3 with Prostavac, and that will be very interesting for advanced disease. And we are just starting an active surveillance trial with this vaccine. It'll be a monthly vaccine with the primary endpoint measuring immunostaining of CD4 and CD8 cells in the prostate tissue. So it's a little fast, apologize, but the slides are available for anybody who's interested, and thank you very much for your attention.
Thank you very much, Howard, for managing this very difficult task, I know. And there are a lot of puzzles here in the chemoprevention, so you did a great job. Thank you, and the paper is open for discussion, questions. Alex, please.
Great talk, Howard. No, you're done, but not.
Okay.
So, I mean, Metformin is high on the agenda. Neil with us, David Margell, published recently several papers. The metabolic syndrome is high on the agenda. How does that confound? I know these are randomized studies, so by definition, some of the studies might not have been confounded by some other confounders. But when you show the influence of the what could be the metabolic syndrome and some of the drugs that were, did you make sure that on all these drugs, some of the parameters that are favoring prostate cancer or preventing prostate cancer were actually accounted for? It only comes now high on the agenda, might not have been on the radar before. So the summary, what is the influence of now somehow established drugs or parameters on prostate cancer and prostate cancer risk in trials which were using preventive measures? So
specifically metformin?
Metformin and others.
So the data from metformin I think is among the most interesting, and I just recently reviewed this because Machi was kind enough to share a paper with me that they're working on, looking at metformin as a risk factor for incidence. And their work, if I may say, it's okay, conforms with the very pretty extensive literature that metformin is not associated with prostate cancer incidence. But there are other data to suggest that it is associated with a reduction in prostate cancer and actually overall cancer mortality. And so there are mechanisms by which, you could, this is very interesting, AMPK activation, mTOR inhibition is one potential which would have an effect on proliferation, or perhaps an indirect effect through the IGF axis, despite the fact that we did not see an IGF axis relationship. So there's ways it could work. There is epidemiologic data to suggest that it doesn't reduce incidence, but it could reduce mortality, which I think makes it an ideal drug to use in the active surveillance setting to prevent progression. So that's sort of my thinking on metformin. The diabetes, the fact that diabetes is associated with a lower risk of prostate cancer doesn't explain the metformin data, because most of the metformin studies look at diabetics in large cohorts and look at those on metformin versus not on metformin. And in that group, metformin seems to be protective.
May I ask you a question?
Yeah.
The PSA vaccine that you mentioned, did I understand it correctly? This is not an individualized vaccine like Sibulacil. This is
excellent point.
Yeah.
Exactly. This is an off-the-shelf vaccine. It is not individualized. It's a vaccine, a pox viral vector vaccine with a prime of vaccinia and a boost of fowlpox, and 3 co-stimulatory molecules that seem to amp up the immune response to the vaccine.
So, and if it turns out to be active in the active surveillance cohort where you test it now, do you have an idea at which price it would be marketed thereafter?
Well, that's a great question. It shouldn't be as expensive as the other one because it's not nearly as complicated. I think the much more immediate use for this will be in metastatic disease, and that's where a large phase 3 is being done. So active surveillance is, we're only taking a baby step with a 90-person study to see if we can see some effects on immunostaining. But the 500-person phase 3 trial in minimally symptomatic metastatic castrate-resistant prostate cancer, if that holds up, if those curves hold up the way the Sipuleucel T curves hold up, you'll have definitely another approved vaccine that will be easier to make, and I certainly hope that it's a lot more affordable than the one on the market. Dr. Klotz.
Last question.
The surveillance patients ask me all the time, and I'm sure other people, I want
Microphone.
to be proactive, what should I take? So what should we be telling them? Take nothing, or is there something you think there's sufficient evidence?
I'm tempted to tell them to take the 5-alpha reductase inhibitor. There we have data from the REDUCE trial that if you're not exactly a surveillance population, it's true, but you're more likely to have a completely negative biopsy if you're on a 5-alpha reductase inhibitor. I don't tell people that. I think that we don't have evidence that it helps. Some people will have high-grade disease, and some people will put 2 and 2 together and say the drug caused the high-grade disease. So I do not go in the 5-alpha reductase direction in that group, although I think it might actually be beneficial, and it might help you find the high-grade disease. Of course, we use the imaging, so we maybe don't have as much problem finding high-grade disease. If their vitamin D levels are very low, less than 20, they should have supplementation because nobody should have a vitamin D level less than 20, but we do not advocate high doses of vitamin D. And I advocate a heart-healthy diet because I tell them they're more likely to die of heart disease than prostate cancer.
Thank you, Howard. So I think